the tumor biology is very distinct for triple negative breast cancer. And we have definitely come a long way from the past, and, the outcomes are improving year by year, but, they're not as drastic as you would consider for a hormone receptor type of breast cancer or a HER2 positive breast cancer.
Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. Welcome back to The Cancering Show. I'm Dr. Jennifer Young-Pierce, and today we have a very special guest, Dr. Ayesha Munir. She is a hematology oncologist at USA Health Mitchell Cancer Institute and an assistant professor in interdisciplinary clinical oncology. Dr. Munir completed her fellowship at Georgetown University and specializes in the treatment of breast cancer. She is here to discuss the critical intersection of the BRCA gene, breast cancer, and health disparities, in particular to shed light on the impact of socioeconomic status, race, and ethnicity, not only in cancer outcomes, but in cancer research. This is an incredibly insightful and impactful conversation, and she has a wealth of knowledge. Let's listen to Dr. Munir. So, Dr. Munir, welcome to the show.
Thank you for inviting me. Delighted to be here.
So we are super excited to have you on faculty at the Mitchell Cancer Institute, and so excited that you have joined our team. Can you tell our listeners just a little bit more about how you ended up at the Mitchell Cancer Institute and kind of why oncology?
Yeah, absolutely. So I feel privileged to be part of the faculty at the Mitchell Cancer Institute. This is my first job out of training, so really excited to be here and in Mobile. I would say I was always interested in oncology. Going way back into my med school, my first exposure to a cancer patient was actually my best friend's dad, who got diagnosed with a stage 4 lung cancer. And I think we were in high school at that time. He passed away very quickly. I ended up in med school, went through those few years of training, and towards the end of my final year was in the hemonc section of training with all the attendings there. And that was the time when immunotherapy was becoming the big thing in the field of cancer. And I would always hear my attendings they would talk about this immunotherapy coming into the treatment for all these cancer types after chemotherapy. So that was a huge breakthrough, and they would talk about it with excitement. Of course, I was going through leukemia and lymphoma wards as well. So, looking at all those things, bone marrow transplant, one of my favorite subject in med school was immunology. So, how the immune system works and how these tumor cells, they evade the immune system to become, the cancer cell that they are, and how aggressive the disease becomes. So I think all of those things, they culminated in my interest in, becoming an oncologist in the future. So with that in mind, after, I completed my training, I, came to the States, did my residency, and that is when I started becoming more interested in breast cancer.
Okay.
With the rising global incidence of this cancer, and, with my little bit of previous experience with public health and some health disparities in my country back home, and then, reading about and knowing about the health disparities that exist in women in breast cancer, that really, piqued my interest in that. So headed to Washington, D.C. For my fellowship, and was always interested in academics, wanted to spend my time in research and teaching, along with, being a clinician, because I truly believe that the future of oncology lies in research and in clinical trials. And, that is from where we've come so far with all the treatments and all the different types of cancers. So this opportunity came along, and I was interested in it, and it worked out. And I just wanted to say goodbye to the Northeast winters.
Yes.
And have some warm summers. So just decided to move here.
Right.
Yeah.
And of course, here we sit and the country is covered in Arctic chill.
Yes, absolutely.
So I loved your particular interest in disparities and breast cancer. We've actually spent a lot of time talking about that on the podcast with our listeners, and I think they are very aware of the disparities that we see in the Southeast and across the country in minority populations based on rurality, poverty. But tell me particularly what interests you about the healthcare disparities, and where do you see the biggest opportunity for impact?
Yeah. So, particularly talking about the breast cancer. So just to give you a little background about why I got interested in health disparities. After I completed and graduated from my med school, I spent a year in public health. And this was back home. Those were the projects that were funded by Bill and Melinda Gates Foundation. And they actually focused on pediatric health, so under 5 child mortality in the developing world and malnutrition. But a huge concept of those projects was the health disparity that exists in different socioeconomic statuses and the inequitable distribution of health access to certain individuals that results in disastrous outcomes for their diseases. Mm-hmm. So I spent a year on those projects, and that is where I really got interested in health disparities. And when I decided to enter the field of oncology and, become a breast oncologist, as we know, I quickly learned that although this is a very common cancer to be diagnosed, not just in the United States, but globally, but the health disparity is humongous within the breast cancer field among, different racially ethnic groups or people of color or women of African ancestry. So that was what piqued my interest in health disparities. Mm-hmm. My focus, moving forward as I advanced through my career is to really hone down on this, while I'm at the Cancer Institute, looking at our health disparities in our local area, especially with our own patient population, because I feel that the more we document that in literature and the more awareness we have about it, that's the only way to really come up with the solutions about health disparity. We know from our large population-based studies and, the literature in the past that although if you look at the incidence of breast cancer is more in white women as compared to women of color or women of African descent. But if you compare the stage per stage mortality or breast cancer specific mortality or morbidity or the outcomes, they are worse in women who are of African ancestry or, our Black population, and even women of other racially diverse groups like Alaska Native or Pacific Islander. So I think it's very important to really look at that, see what are the factors that are contributing there, and see how we can improve upon them to really have that equitable distribution of, healthcare for all these patients.
Sure. I so appreciate you kind of really spelling out what we're looking at. And, a lot of data has been done to define the issue, but, we're so interested in projects that can make a real impact. We've talked a little bit about, and I love that you brought up the nutrition. We've talked about differences in nutrition and how that might affect cancer outcomes and cancer survivorship. We've talked about DNA and genetics. And of course, we've talked about the immune system and not just how cancer evades or kind of hides from our own immune systems and the medicines that we can use to stimulate that, but also kind of how possibly racism, systemic racism, because we know that disparities are different in women of African descent, but those disparities don't necessarily exist in Africa between two sets of Black women. And so when we look at those disparities of maybe non-access issues, kind of what are the things that you feel like we can impact the most quickly? Where would you like to see us looking?
I think if I would have to talk about that, maybe definitely we know that the socioeconomic status really does play a role in this health disparity. And probably that is a huge issue that needs to be dealt with, not just at a regional level or at a level of one cancer center, but nationally. So, I'm hopeful that, the government comes up with different programs that can be aimed at that. On an individual level, at the level of, our cancer institute, I would be hopeful that, we can maybe start at least, maybe going into the communities and educating these women more, because the data does show that there is also a disparity in knowledge. So, there is a difference in a knowledge that white women would have for the most part regarding screening purposes versus a Black woman or women of, other racially diverse groups. Has that to do with education, or again is related to maybe, yes, the socioeconomic status, but maybe doing more, community outreach work, and, really making them aware of, for example, the screening for breast cancer, because it has come to my knowledge over the years, and more recently when I've started my work here, is that a lot of, and that is what I've noticed, that a lot of Black patient population, they're really presenting at a very late stage of disease. They're really sitting on their tumor that is growing throughout the years. And for the most part, they don't really know the advantage to screening or how important a screening mammogram can be. So I think those things are very important. That is something that is easily achievable, and it can be set as a short-term goal. My focus would definitely be on that. And of course, along with that, if in any way we can try to help them to make sure that they can adhere to at least their annual screenings, showing up to their primary care appointments or their oncology appointments, that would be important. But community outreach is something I feel that we can really make a huge impact on.
Sure. And, fits right in with the community engagement that we're already doing at the Mitchell Cancer Institute, and I think on a national level. Some of the data does suggest actually that Black women and white women are getting mammograms at the same rate. And so that alone doesn't explain some of these more advanced diseases. And so I know one of the things that comes up a lot is this question of triple negative breast cancer, a more aggressive type of breast cancer in some women. Talk to us a little bit about that.
Yeah, absolutely. And I think I would definitely agree with you that screening is not the only reason why some women are presenting at a very late stage of disease. And that has to do a lot with disease biology itself. So quickly talking about this triple negative subset, anytime a breast cancer, and this is just for the listeners so that they know what type of, a breast cancer we're talking about. So every time a breast cancer is diagnosed, it is tested for 3 proteins. These are the receptors that are found on the breast cancer cell, and this is a universal test that is done. They are tested for estrogen receptor and a protein called progesterone receptor. Those 2 make up your hormone receptors, and then there is a third protein called HER2. Anytime a woman's cancer does not display these 3 receptors or is tested negative for these 3 receptors is when you categorize that breast cancer as a triple negative breast cancer. And from our research and our studies, we know that as compared to the other types of breast cancer, the triple negative breast cancer is the most aggressive type of breast cancer biologically. Majority of the patients would present at a later stage of disease. If they would present at an early stage of disease, there is a higher chance that they will present with a larger tumor size. Most of the time, there will be lymph node involvement. It will be a locally advanced disease. You would be looking at the biology where, the cells are really dividing aggressively, high chances of metastasis. And then these patients, unfortunately, have this high risk of this cancer coming back pretty early, even after a cure for an early stage breast cancer. So we're talking about a recurrence or the cancer coming back within 1 to 3 years after their treatments. Wow. At a later stage, when this cancer presents, it's notorious for coming, in the in the organs rather than in the bone as compared to the other disease subtypes. And unfortunately, as compared to its other types of breast cancer, the other counterparts, triple negative breast cancer really in today's day and age, we're still lacking good targetable drugs for this disease. So we're really talking about chemotherapy as being the backbone of treatment for this disease. Of course, a lot of work is being done, but unfortunately, that breakthrough has not been made. Mm-hmm. We have definitely come a long way from the past, and the outcomes are improving year by year, but they're not as drastic as you would consider for a hormone receptor type of breast cancer or a HER2 positive breast cancer.
Okay.
Because we were talking about this previous question about health disparities and the screening mammogram, the tumor biology is very distinct for triple negative breast cancer, and there have been some studies that have been done which show that as compared to a white woman, a black woman is more at risk of getting a triple negative breast cancer. So talking about triple negative breast cancer, the common presentation of this disease would be a woman who is in her young to middle-aged years, wow. African American, presenting with an early stage or a locally advanced disease, with a big tumor size and nodal involvement, and for the most part, maybe being positive for a genetic mutation like BRCA1 or 2. So that is a classic case of triple negative breast cancer that you would see. Of course, we do see triple negative in our white population, and we do see triple negative breast cancer at a very early stage without any nodal involvement. But when we talk about the classic cases, we're really talking about our women of color and women of African ancestry presenting with this disease type. And there have been, documented data and published data that tells us that Black women, they're actually 2 to 4-fold. They're at a risk of triple negative disease way more than their, white counterpart. So, our Caucasian patients, 2 to 4-fold increase in incidence in triple negative breast cancer among Black women and women of other racially diverse groups. Okay. So, this disease does affect our Black population more significantly because we know that this is an aggressive disease. So the breast cancer specific mortality and the morbidity and the complications are really higher in our Black population. Now, there are some studies that have been done in the past, and there are some studies that are going on to really know that why our Black population is at a risk of triple negative breast cancer. We've talked about the socioeconomic status. We've talked about the health disparity, access to health care. But certain studies have noted that even if you adjust for those factors, the Black population is still at a high risk of this disease subtype. And there is a very interesting study that is coming out of Indiana University. And to the best of my knowledge, I don't think it's published yet, and it's still going on. And the researchers over there, they're really trying to look at the biology of a normal breast tissue of an African American woman. And what they found out was that there is a certain specific cell type that is present in the Black women's normal breast tissue in a very high amount. Okay. That is the similar cell type that is increased in high quantity when the white women get triple negative breast cancer. So that's very interesting that, in our Caucasian patients, that cell type really increases in amount when they're about to get this, this type of breast cancer. And that is naturally in such a high amount in our patients or in our women of African ancestry. So there is a lot of debate about that. It might not just be the health disparities or access to health care after all, but it has to do a lot with the basic biology of the breast tissue, and it might be very different in a Caucasian patient as compared to a patient of African ancestry or other racially diverse groups. Sure. So very interesting studies going on.
Well, and to go back literally to basics, a lot of people, when we talk about race and racism, we say, we are all Homo sapiens. There is no separation by race. And that the biologic differences might actually, like we were talking about before, be constructs of systemic racism that are, post-genetic modifications related to the stress of living in a racist society, whether that's the, environmental stresses are increased or, societal pressures. We talked about elevated cortisol. Kind of, how do you feel like those external things can play into this kind of biologic outcome?
So I have come across a few studies that have, hinted at these factors, especially being exposed to a stressful situation with your cortisol rising and the impact of that on your changing disease biology. We know that from our, studies that are published. And I would agree with you for the most part that, yes, those factors might absolutely, play a role in a disease type becoming aggressive, more so for, our Black population. So definitely, I think that's a very important factor to look at. And, with all these ongoing studies, I hope that, we're able to really get to the disease biology of a Black woman's breast so that we really know, where the culprit lies.
Right. And, to continue down this road, but let's talk about hope. What are the treatments that are really working well in triple negative? Because I know the mortality has gone down. So where are the real inroads being made?
Yeah. So as I said earlier, that although, we still lack a lot of targetable drugs for this type of disease, but we've really made a headway in terms of treatment when we compare the treatments that we have right now to the treatments, that were being given in the past. So the systemic backbone still remains the chemotherapy. But, talking about the early stage triple negative breast cancer, the recent advancement was the Keynote 522 trial that came about where they added immunotherapy, pembrolizumab, to the systemic chemotherapy backbone. Along with the doxorubicin, cyclophosphamide, and paclitaxel, we added the chemotherapy drug called carboplatin. We know from our studies that this drug has really shown benefit in terms of achieving pathological complete remission in triple negative breast cancer. And triple negative breast cancer really responds beautifully to carboplatin. So this trial combined immunotherapy with these 4 chemotherapy backbones, and we're using this treatment in the neoadjuvant setting, so using it upfront prior to surgery for early stage triple negative breast cancer that is 2 centimeters or more, or between 1 to 2 centimeters with lymph node involvement. We do this, then take the patient to surgery, which is followed by a couple of cycles of immunotherapy alone after the surgery. And this trial has shown that adding immunotherapy to the chemotherapy upfront increases the chances of achieving pathological complete remission. So there is a very high chance that when the patient is taken to surgery, you are going to achieve that. And, there is not much residual disease that is left. We also know from our data that having achieved pathological complete remission in a triple negative breast cancer patient translates to, the disease-free survival and eventually overall survival for these patients. So I would say that's probably one of the biggest advancements that we've made in the triple negative breast cancer world. Yeah. And similarly, there's another trial that came about, the Keynote 355, where they've combined immunotherapy with systemic chemotherapy as the first-line treatment for a stage 4 triple-negative breast cancer. So, if you have a patient who has a metastatic disease, a stage 4 triple-negative breast cancer, and their PD-L1 status is high.
So they have a marker.
They have a marker.
That the immunotherapy would work.
Yeah. Yes. So, if that marker is high enough, then you can combine this immunotherapy with the systemic chemotherapy backbone, and that has really improved the survival as well.
Well, that is excellent news. And I know our patients are all really on top of things, and I'm very interested in adding immunotherapy to current treatments. And, for those of you listening, you will probably find that this applies to almost every cancer and absolutely is always worth asking the question, is there a role for immunotherapy in this cancer? And should it be used upfront, first line. In many cancers, it has moved up the chain of command. We talked about this a little bit before. We used to give it last at the very end and, in the original clinical trials, and then slowly has made its way. And in most cancers these days, immunotherapy is often given first line for more advanced disease. So always worth asking that question. Dr. Munir, thank you so much for coming into the studio today to talk to us about breast cancer and healthcare disparities. You are a wealth of knowledge, and I know our listeners are really going to learn so much from you, and so appreciate it.
Thank you so much for inviting me to your podcast today, and I hope that I was of help to our listeners. Thank you.
You were so much help that we can't wait to have you back.
Yes, absolutely. I'll be happy to come and share some more knowledge.
Excellent. I want to thank Dr. Munir for giving us such valuable insights into the importance of addressing health disparities and equitable healthcare access. It is so important to shed light on the need for local and national level solutions and community outreach programs. We haven't spent enough time on it, and it's information that every cancer patient needs to know. So look forward to that. Until then, keep cancering and take care of yourself. Thanks again for listening. And don't forget to submit your questions at www.cancering.com. We're here for all of those questions and we'll get you the answers. This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.